Let's talk about brain abscesses. So the majority of these are caused by hematogenous spread from a distant source, such as a pulmonary infection or bacterial endocarditis. Some other causes can include direct extension from a nearby infection, such as a middle ear infection or a sinus infection. And trauma and neurosurgery can also introduce these bacteria into the brain. So most of these abscesses are going to be polymicrobial, but some of the most common organisms found will include viridans streptococci, including anaerobic ones, staphylococci, and that's especially in cases where there is a neurosurgery or trauma, and gram negatives. So the inflamed artery can also form a mycotic aneurysm, which makes the artery brittle, and when it ruptures, it can lead to an intraparenchymal or subarachnoid hemorrhage. So the clinical features, usually with an abscess, this will be more of a subacute onset, maybe over weeks or so. You may have a history of an antecedent pulmonary, ear, or sinus infection. The most common symptom is headache. Otherwise, there can be drowsiness, confusion, seizures, and focal neurologic deficits depending on where the abscess is. Importantly, fever and leukocytosis are not consistently present, and that can be due to encapsulation of the organism. So acute symptoms can sometimes happen, but that's more typically in, for example, if there's endocarditis and there's a septic infarct or a hemorrhage. So evaluation usually starts with the CT head. Now, on the CT scan with contrast, there will be a ring-enhancing lesion, as seen here. And usually it's also hypodense in the inside and in the nearby surrounding, which represents edema. So an MRI is typically done, and that will show a contrast enhancing lesion on the T1 modality. And so in the inside, it will also be hypodense. One thing to note is that you won't see it well on this particular MRI, but on the medial side, the wall is thinner, and so sometimes these abscesses can rupture medially. On the T2 sequence, the lesions will be hyperintense, and especially surrounding the lesion, that'll represent vasogenic edema. Abscesses, just like strokes, can be diffusion restricted, and so it will appear on the DWI scan as well. So the other parts of the evaluation will include a sedimentation rate. This is typically positive. A chest x-ray can also help in identifying pulmonary infections, and blood cultures can be helpful for tailoring your antibiotics, although note that these are typically negative unless there's also a meningitis, which there's typically not a meningitis. So a brain biopsy can be very important in giving a definitive diagnosis as well. Lumbar puncture is contraindicated, especially if there's increased ICP suspected. However, sometimes these are inadvertently done, and there's typically no organism found unless there's also a meningitis present. And you can see mildly elevated white blood cell counts, typically neutrophilic, as well as slightly elevated proteins with a normal glucose level. So for treatment, if you see a hemorrhage on one of the scans, you'll have to stop any anticoagulation that the patient's on, as well as antiplatelets. A neurosurgery consult is typically done both for diagnosis and treatment with aspiration or excision. Empiric antibiotics are typically started, and the actual regimen depends on the source, but one empiric regimen can include vancomycin, ceftriaxone, and metronidazole as an example. After susceptibilities come back, then the antibiotics will be targeted for the susceptibilities and can be narrowed, but the antibiotics are typically continued for 1 or 2 months. Dexamethasone can be started if there's mass effect, and the patient will also need correction of cardiac abnormalities, such as if they have valvular endocarditis. So for prognosis, mortality highly depends on how quickly treatment was initiated. So if the patient is still alert when treatment starts, mortality is pretty low, typically 5 to 10%. However, if they've progressed to being comatose by the time that treatment started, then mortality is over half. And if there is a rupture of the abscess, especially into the ventricle, then the mortality can be near 100%.